All right, thank you for the introduction. So breast and ovarian cancer are the second and fifth leading causes of cancer deaths among women in Canada. And genetic predisposition plays an important role in an individual's susceptibility to these cancers, particularly for individuals with germline mutations in BRCA1 and 2 DNA repair genes. And while the general population's lifetime risk of breast and ovarian cancer are 12% and 1.3%, individuals with BRCA1 and 2 mutations have risks up to 72 and 44% respectively. And importantly, no effective screening method for ovarian cancer currently exists. So as a result, the gold standard preventative option for high-risk people with BRCA mutations is to undergo risk-reducing bilateral Salpingo-Oophorectomy, or RRBSO. And this is the surgical removal of both ovaries and fallopian tubes and has been shown to reduce the risk of breast and ovarian cancers by up to 75 and 96% respectively. Guidelines recommend BRCA1 carriers to undergo RRBSO as early as the age of 35 and BRCA2 carriers as early as the age of 40. However, despite the effectiveness of undergoing this surgery at the recommended age, it also places people into immediate premature surgical menopause with the accompanying adverse health outcomes. Research has thoroughly investigated the negative health outcomes of premature surgical menopause in the general population, including increased risks of cardiovascular disease, osteoporosis, cognitive impairment, anxiety and depression, and total mortality. However, relatively little is known about the long-term health consequences in high-risk people with BRCA mutations. Also, while hormone replacement therapy is readily recommended and used to mitigate many of these health concerns in the general population, its use among BRCA carriers is a more complex decision due to the concern of increasing the already high risk of breast cancer in these people. So we wrote a review that summarized the research on long-term non-cancer risks in BRCA carriers following RRBSO, and we highlighted the existing evidence on the use of hormone replacement therapy in this population. So 4 studies to date have examined indicators of quality of life in the BRCA population following premenopausal RRBSO and have reported worse vasomotor symptoms, decreased sexual function, and increased depressive symptoms. 2 of these studies were able to examine the impact of hormone replacement therapy and reported that people receiving HRT treatment had significantly fewer vasomotor symptoms and improved sexual functioning compared to non-users. 8 studies examined cardiovascular health outcomes following RRBSO, with the majority being of cross-sectional or case control study design. And 1 high-quality cohort study compared the risk of cardiovascular disease after premenopausal RRBSO with 2 age-matched control groups, those who underwent bilateral oophorectomy for benign conditions, and those with intact ovaries who had a hysterectomy or a self-injectomy. And they found that while BRCA carriers had a significantly higher risk of cardiovascular disease compared to controls with intact ovaries, these people were still less likely to be diagnosed with predisposing conditions and less likely to fill cardioprotective medications. So overall, these findings highlight that prevention of adverse cardiovascular outcomes can be improved in the BRCA population by placing more focus on post-RRBSO follow-up care. 6 studies explored the impact of RRBSO on long-term bone health. However, studies were limited by small sample sizes and young mean ages cohorts when examining these long-term outcomes. However, studies did still report adverse effects of premenopausal RRBSO on bone density, risk of osteopenia, and risk of osteoporosis. Also, available evidence indicates that HRT is important in reducing the bone density losses and in improving bone strength in people who underwent premenopausal RRBSO. With regard to hormone replacement therapy in the BRCA population, HRT uptake and sustained use unfortunately remains low, with studies reporting an uptake of between 8 and 47%. While the average age of our RBSO is around 40 years, studies are reporting that the average duration of HRT treatment is only 2.8 to 3.5 years. So considering the many adverse health consequences of premature surgical menopause and the success HRT has at minimizing these health risks, HRT use among BRCA carriers should ideally be sustained until closer to the average age of natural menopause. This low HRT uptake is likely driven by the concern that use may counteract the breast cancer risk reduction of undergoing our RBSO in the first place. However, to date, 8 studies have evaluated the effect of HRT on breast cancer risk exclusively in BRCA mutation carriers, and the available high-quality observational data suggests that HRT use up to 5 years following premenopausal RBSO does not increase the risk of breast cancer, and further research is still needed to confirm even longer-term use. So this review highlights the growing evidence of multiple adverse non-cancer health outcomes associated with undergoing our RBSO, and that these adverse outcomes can be improved with HRT treatment. Also, the available high-quality observational research strongly points to no increased breast cancer risk following up to 5 years of HRT use. So overall, evidence supports activities that will spread awareness that HRT use post-premature surgical menopause is safe among BRCA carriers and is important for both maintaining quality of life and reducing long-term adverse outcomes. And I would like to conclude with a thank you to the co-authors of this paper. Thank you.
Greetings, everyone. We are Anila Lacroix and
Rukie Karov
from the Brado Lab, and we are research assistants with Dr. Lori Brado and co-investigators for the various benefits of delivering tailored cognitive behavioral therapy and mindfulness-based therapy to gynecologic cancer survivors to support them in gaining sexual health and improved quality of life after treatment. So thank you so much for joining us and listening to our presentation. Advances in cancer treatments are extending the life expectancies of gynecologic cancer survivors, but these treatments often result in distressing post-treatment symptoms that negatively impact patients' quality of life. A critical issue is sexual dysfunction, affecting up to 90% of gynecologic cancer patients. Surgical interventions combined with radiation and chemotherapy can cause significant physical, psychological, and hormonal changes, leading to sexual difficulties such as vaginal atrophy, dryness, body image issues, and decreased arousal and desire. These symptoms contribute during intercourse, chronic low desire, and sensual and sex-related distress. Despite the high prevalence of sexual dysfunction among gynecologic cancer survivors, healthcare systems often do not address these concerns. Patients face barriers such as stigma, social embarrassment, and uncertainty about how and with whom they can discuss their sexual health. Even when patients communicate their concerns, they report often encountering reluctance or a lack of knowledge about how to best support them. The multifaceted etiology of sexual health issues in this population suggests that psychosocial interventions like cognitive behavioral therapy, CBT, and mindfulness-based therapy, MBT, can be effective. CBT focuses on modifying negative thought patterns and increasing engagement in pleasurable activities, while MBT involves non-judgmental awareness of current sensations through mindfulness practices. Unfortunately, only a third of gynecologic cancer patients receive adequate sexual health support. To address these gaps, research has explored the benefits of digital tools for delivering psychological interventions. eSense is an online platform offering MBT and CBT for sexual dysfunction in women through interactive and instructional videos, audio files, examples of patient cases, and downloadable exercises. Studies have shown that eSense significantly improves outcomes in addressing sexual desire, arousal, satisfaction, distress, depression, and overall well-being. Our study aims to adapt eSense to the specific needs of gynecologic cancer survivors. We collaborated with a patient advisory board to refine the platform, thus creating eSense-Cancer, tailored to address the unique sexual health challenges faced by this population.
Hello. Today I'll be discussing the methods section for phase 1 of eSense-Cancer, followed by the emerging results section. To adapt eSense to eSense-Cancer, we formed an advisory group of survivors from 2 online gynecological cancer support groups using a convenient sampling method. Eligibility criteria included being at least 19 years old, a gynecological cancer survivor, fluent in English, and comfortable using digital platforms with access to the internet. We recruited 6 participants experiencing sexual difficulties due to their cancer treatments who became our advisory board and patient partners. To protect their identity, we did not collect information on diagnosis, age, name, or location. For procedures, after being randomly assigned to either the CBT or MBT arm of eSense, patient partners completed and reviewed their assigned modules. Using Qualtrics, we administered questionnaires after each module to capture their insights and feedback. The lead researcher then compiled these responses into a master document, which was used to generate open-ended discussion prompts for the subsequent focus groups. For the focus groups, we conducted 3 focus groups in total via Zoom, 2 for CBT and 1 for MBT. While the content for both modules were the same, the CBT module generated more responses, necessitating an additional discussion. Each session lasted 2 hours and was facilitated by the lead researcher. Sessions were recorded, transcribed, verified for accuracy before being used for thematic analysis. For thematic analysis, we used NVivo software and followed Braun and Clark's thematic analysis in psychology method. First, each researcher read their assigned data sets and generated initial codes, which were then compared and refined into a code book and used to recode the data. This process led to the identification of broader categories and the emergence of distinct preliminary themes. We used an inductive approach, which is identifying themes based on the data itself rather than pre-existing theories or concepts. We are now in the process of analyzing the data at a semantic level, focusing on explicit meanings and direct statements from our patient partners. Once the final themes are generated, they will be used to adapt specific areas of eSense program to better suit the experiences of gynecological cancer survivors. For compensation and ethical consideration, patient partners were compensated $40 per hour for their work, totaling 20 to 30 hours. Following the Research Ethics Board recommendations, the advisory group is considered expert opinion rather than an experimental procedure. Therefore, formal consent processes were not deemed mandatory. I'll now go into the emerging themes. Our current analysis is revealing several key themes under the categories of content and format. These are preliminary themes again, and we're in the processes of generating the final themes. We currently observe the emergence of 11 preliminary themes for content, including 27 sub-themes, and 1 theme for format, including 3 sub-themes. Under content, we have adaptation, inclusivity, which focuses on sub-themes of clarity and intentions, pain sensation, treatment side effects, body image and scars, transition, systemic failure, relationships, which covers relationship challenges, partnered sex, unpartnered sex, and communication, sexual symptoms, fatigue, and miscellaneous. Under format, we have 3 sub-themes, including formatting, functional accessibility, and contradictions. Once the final themes are generated, they will provide valuable insights into the specific needs and experiences of gynecological cancer survivors, highlighting key areas for adaptation within the eSense program.
So our final thoughts for now and a little discussion. What we learned through our patient partners' engagement was that although their treatments thankfully extended their lives, they had untreated trauma from the existential threat that they had experienced from the moment of their diagnosis and throughout treatment for cancer. Their trauma was compounded by ongoing side effects that permeated into every aspect of their lives, affecting their overall quality of life, including their uncertainty about how they could feel sensual in their altered bodies and in their sexual lives. Our data revealed that our patient partners wished to boost their self-esteem and take charge of their healing journey. They actively sought, but were unable to find resources to help them embrace their treatment-altered bodies. They stated that they wanted support and information on how to handle their psychological symptoms and the resulting biopsychosocial stressors. However, when various themes of survivorship arose, reactions of support often encouraged them to resume life, thus bypassing the profound changes that resulted from their disease and its treatment. Therefore, our patient partners found that eSense-Cancer provided a missing resource, a tool that they could use for reframing their experience and the psychological distress that comes with it. They noted that eSense-Cancer equipped them with the awareness, language, and empowerment they needed to move beyond their identity as cancer survivors. Further, eSense-Cancer's self-directed approach gave them more control over their healing. As we continue with phase 2, moving towards the full clinical trial, we hope that we will be able to work with many cancer care providers to support and provide more holistic healthcare for this patient population, helping them to reframe their narrative around the lived experience of gynecological cancer. Thank you so much for listening to our presentation. Again, my name is Anila, and this is Rukie. And we hope to be able to share a paper with everyone in the near future. For now, I will be attending the question and answer session that follows. So for now, thank you again so much for listening, and we wish you well. Bye.